I wanted to talk about the phase 2 study, HCRN-GU16260, which is a trial of nivolumab and salvage nivolumab plus ipilimumab for patients with treatment-naive advanced kidney cancer. So as background, nivolumab as a monotherapy has been approved for second-line VEGF receptor TKI resistant kidney cancer based on the Checkmate 025 study in 2016, and was the combination of nivolumab plus ipilimumab was approved for the treatment of frontline intermediate and poor risk patients with metastatic kidney cancer based on the Checkmate 214 study comparing nivolumab plus ipilimumab to sunitinib in 2018. However, there was little information that was available on the activity of nivolumab monotherapy in treatment-naive patients with kidney cancer, nor information on the activity of nivolumab plus ipilimumab salvage in patients who didn't respond to nivo monotherapy, or information on how to select patients based on tissue and clinical predictive biomarkers for first-line immunotherapy. And this trial was launched to fill in those various knowledge gaps. The study involved 160 patients. 120 were to have metastatic clear cell kidney cancer, 40 with non-clear cell kidney cancer, and these patients were received nivolumab every 2 weeks for 6 doses, then every 3 weeks for 4 doses, and then every 4 weeks for 3 doses at the scheduled doses. If they had response, they continued treatment until 96 weeks. If they had evidence of disease progression or still had stable disease at a year, they could be eligible for a nivo-ipi boost, which was at the standard FDA-approved regimen and followed by nivolumab maintenance for up to a year. We had 123 patients enrolled in the study, and 34 ended up going on the boost. Of the patients who were just on the part A of the study, 31 are continuing on treatment. 16, I believe, have had were off treatment yet still in response, and 27 were off treatment but with progressive disease, and 15 were deceased. Median age was about 65 years, and 2/3 were performance status 0, and 72% were male. And 24% had an IMDC favorable risk, 65% intermediate risk, 10% poor risk, and 22 subjects had, or 18% had sarcomatoid histology. And the results were interesting. Overall, we had a response rate of about 32% to frontline nivolumab therapy, but it was actually 50% in the patients with favorable risk, with 15 out of the 30 patients having had a response, and 4 of those, are around 13%, having a complete response. The response rate was 25% in the intermediate and poor risk populations. The median duration of response was 19 months, with 14 out of the 15 responders in the favorable risk group continuing to respond at the time of this analysis, which was a median 15.9 months into the study. The median PFS was somewhere around 7.5 months, but had not been reached for the favorable risk population. The sarcomatoid population also had a response rate of around 32%. About 65 patients were eligible for the crossover, but only 34 actually went on to the crossover, because in order to be actually eligible to actually receive the boost, you had to have a biopsy showing residual cancer, and many of the patients who had progressed either did not have tissue accessible for biopsy, or the biopsy did not show residual cancer. In addition, some patients who had grade 3 or 4 immune-related adverse events to nivo monotherapy were not eligible to get the IPI boost, and some patients progressed in a way in which it made more sense for them to get VEGF receptor TKIs than more immunotherapy. Of that group of 34 patients who went on to the boost, 30 actually were evaluable, and 4 of those responded, all partial responses and no complete responses. So when we looked at this data, it suggested that nivolumab monotherapy could be an alternative treatment approach, particularly for those who were averse to getting ipilimumab or a VEGF receptor TKI, and particularly for those with favorable risk, where they would have a potential opportunity to get a boost should they not respond. And this data also, particularly the favorable risk data, is instructive for what we might see in adjuvant studies. But overall, it suggested that, particularly for patients with intermediate and poor risk, but for most patients, if they could tolerate ipi-nivo, that was the preferred strategy, because it produces a higher response rate, longer PFS, better duration of response, more complete responses than what we saw with nivo monotherapy. Although this question will be formally addressed for the intermediate and poor risk patients in the 8Y8 study, which randomizes subjects to either nivo-ipi or nivo, which should be closing accrual shortly. And then finally, we've collected a lot of tissue samples from these subjects at baseline and at time of progression, and we're in the process of analyzing those samples to identify patients who are predictive markers of response and resistance for this patient population. And we also have just presented the data on the clear cell in this subset in this analysis, and we'll be analyzing the data from the non-clear cell population shortly, and also presenting that hopefully sometime in the future.